So taking into consideration the pathogenesis that I've just talked about, the management or the prevention of cardiovascular diseases aims at preventing the individual risk factors. So in diabetes, apart from controlling the blood sugar levels, we need to control the blood pressure. We also need to control the lipid levels, and we also need to use antiplatelet agents. According to the ADA, the recommendation is, in terms of hypertension, blood pressure should be measured at every routine diabetic visit. Patients found to have systolic blood pressure of more than 130 mm mercury or diastolic blood pressure 80 mm mercury and more should have blood pressure confirmed on a separate day. Repeat systolic blood pressure of more than 130 or equal to 130 or diastolic blood pressure of more than 80 or equal to 80 confirms a diagnosis of hypertension. In diabetes, the goal systolic blood pressure should be below 130 mm mercury for most patients. Based on patients' characteristics and response to therapy, higher or lower systolic blood pressure targets may be appropriate. Patients with diabetes should be treated to a diastolic blood pressure of below 80 mm mercury. Lifestyle therapy for hypertension consists of weight loss if overweight, dietary approaches to stop hypertension, dietary pattern, including reducing sodium and increasing potassium intake, moderation of alcohol intake, that is up to 3 units per day for men and up to 2 units a day for women, and increase physical activity. Pharmacological therapy for patients with diabetes and hypertension should be with the regimen that includes either an ACE inhibitor or an angiotensin receptor blocker. If one class is not tolerated, the other should be substituted. If needed to achieve blood pressure targets, a thiazide diuretic should be added to those with an estimated GFR of more than 30 millimeters per minute per 1.73 meters square, and a loop diuretic for those with an estimated GFR of less than 30 mils per minute per 1.73 meters square. Multiple drug therapy, that is 2 or more agents at maximal doses, is generally required to achieve blood pressure targets. In terms of lipids, in most adults, patients measure fasting lipid profile at least annually. In adults with low risk lipid values, that is LDL cholesterol of less than 100 milligrams per deciliter, HDL cholesterol of more than 50 milligrams per deciliter, and triglycerides of less than 150 milligrams per deciliter, lipid assessment may be repeated every 2 years. Lifestyle modification focusing on the reduction of saturated fat, trans fat, and cholesterol intake, increase of omega-3 fatty acid, viscous fiber, and plant sterols, weight loss if indicated, and increased physical activity should be recommended to improve the lipid profile in patients with diabetes. Statin therapy should be added to lifestyle therapy regardless of baseline lipid levels for diabetic patients with overt cardiovascular diseases or without cardiovascular diseases who are over age 40 years and have one or more other cardiovascular disease risk factors. For patients at lower risk than above, that is, without overt cardiovascular diseases and under age 40 years, statin therapy should be considered in addition to lifestyle therapy if LDL cholesterol remains above 100 milligrams per deciliter or in those with multiple cardiovascular disease risk factors. In individuals without overt cardiovascular disease, the primary goal is an LDL cholesterol of less than 100 milligrams per deciliter or 2.6 millimoles per liter. In individuals with overt cardiovascular disease, a lower LDL cholesterol goal of less than 70 milligrams per deciliter or 1.8 millimoles per liter using a high dose of a statin is an option. If drug-treated patients do not reach the above targets on maximum tolerated statin therapy, a reduction in LDL cholesterol of 30 to 40% from baseline is an alternative therapeutic goal. Triglyceride levels of less than 150 milligrams per deciliter or 1.7 millimoles per liter and an HDL cholesterol of more than 40 milligrams per deciliter in men and more than 50 milligrams per deciliter in women are desirable. However, LDL cholesterol targeted statin therapy remains the preferred strategy. In terms of antiplatelets therapy, the recommendation, according to the ADA, is consider therapy, aspirin therapy, 75 milligrams to 162 milligrams per day as a primary prevention strategies in those with type 1 or type 2 diabetes at increased cardiovascular risk, that is 10-year risk of more than 10%. This includes most men more than 50 years of age or women more than 60 years of age who have at least one additional major risk factor. That can be family history of cardiovascular disease, hypertension, smoking, dyslipidemia, or albuminuria